Okay, hi everybody. This is Avash Kalra, one of the hepatologists at the University of Colorado. Thanks for joining the webinar today. I'm also the course director for our hepatology and liver transplant webinar series. We do have CME and nursing credit available, and all that information is on our website. And Lindsay Carter is going to put all that information in the chat as well for any of you interested. And I would encourage those of you on watching live to apply for that, since it will help you down the line. I also want to go ahead and introduce our speakers today. Really appreciative of Amy Brumenschenkel and Lindsay Pratt, two of our very experienced clinicians in our clinic. In fact, I was thinking earlier that they've been taking care of patients with liver disease longer than about half of our faculty members, and are really, really integral part of our team, and we love working with them. They're going to talk about management of liver disease and cirrhosis in the clinic and frequently asked questions. So hope everybody enjoys the talk. And Amy and Lindsay, thanks for doing it.
All right. So like Dr. Collier said, we're going to talk about management of liver disease and cirrhosis in the clinic and address the most frequently asked questions we get from both providers and patients, and maybe dispel some myths today about liver disease management as well. And I've been a PA in hepatology for about 13 years now. Amy, I'll let you introduce yourself.
Yeah, so I've been working with this team for just over 9 years now, and we're going to try and cover a heck of a lot of information. And so we're going to try and kind of blast through everything, and then if hopefully there'll be a few minutes at the end for any additional questions people have. So just to go through the CME information, like Avash said, Lindsay will have it in the chat. We have no disclosures, no financial relationships that prevent us from making this talk. Nursing credit is also offered. I did just learn it sounds like you can do like listen later and get nursing credits, but for the CME credits, you do have to listen live to these webinars. There is the Rocky Mountain Highlights in Gastroenterology and Hepatology coming up August 9th, and I believe that's free to everybody. Here's some information and a QR code if you guys are interested in signing up for that. And then you do have to fill out a survey for your CME, and it does need to be done by the end of the month. So just do it today and get it done with if you can. Okay, so these are the frequently asked questions related to cirrhosis that we get most often. So we're going to try and cover some pretty big topics, but we're not necessarily going to go through the management of every disease process. This is just going to be to hit some of the highlights and the questions that people have. And so we're going to get through contraception and HRT, herbal supplements, medications, as well as clearance for elective surgeries, MASLD MASH, screening and treatment option updates. We're going to talk a little bit about hepatic encephalopathy, more specifically what protein intake and ammonia levels, the roles that they play, difference between cirrhosis and liver failure, and then just an update on sobriety requirements related to liver transplant.
Okay, so starting with what forms of contraception are safe for patients with liver disease and cirrhosis. So first of all, why should we be talking about contraception with liver patients? So many women with chronic liver disease can actually have impaired fertility. So both patients and providers might not necessarily be thinking about the potential for pregnancy. And there's some potential dangers of unplanned pregnancies with patients with chronic liver disease. For example, large hepatic adenomas can grow with exogenous estrogen. There are certain liver-related medications, for example, Myfortic, that we use in autoimmune hepatitis or recently post-transplant, that are not safe in pregnancy. And then, of course, risk of severe complications during pregnancy with pre-existing liver disease. For example, alcoholic liver disease that's not in remission, poorly controlled or flaring autoimmune hepatitis, and risks of portal hypertensive complications, including bleeding during pregnancy. So just a reminder about estrogen and clot risk in the liver. So With the first pass effect, orally administered estrogen undergoes this extensive metabolism in the liver before it reaches the systemic circulation. And essentially, it increases the liver synthesis of pro-clotting factors and decreases some anti-clotting or anticoagulant proteins. It kind of shifts the balance towards hypercoagulability and then increases the risk of clot. This risk of clot is route dependent, so oral estrogen confers a higher risk due to this first pass effect, while transdermal estrogen bypasses the hepatic first pass effect. It doesn't change the liver's production of coag factors, and so it doesn't increase the thrombotic risk. So combined oral contraceptives, or COCs, these are containing estrogen and progestin. They're both primarily metabolized by the liver. Safety concerns, there's a little bit higher risk of clot in COC users than non-users, about 3 to 9 per 10,000 versus 1 to 5, and of 10,000 in non-users. Rare risks of liver enzyme elevations and cholestatic injury, but this was typically seen with older, higher dose regimens. Current regimens don't really carry any higher risk than placebo. Rare stroke, hypertension, drug-drug interactions. The typical failure rate is 9%. COCs are considered safe in women with compensated cirrhosis, but you want to avoid them in decompensated cirrhosis or decompensated liver function due to concerns about impaired estrogen metabolism. And they're not advised in patients with Budd-Chiari or for patients with hepatic adenomas. And these are sort of the 3 high-risk groups that you want to think about, or that should give you pause with hormones. It would be patients with decompensated cirrhosis and liver function, hepatic adenomas, and Budd-Chiari, which I'm going to talk about here. So HCAs are benign tumors that have a rare risk of malignant conversion or rupture. They're way more common in females, although we are starting to see them in male patients. They're associated with metabolic disorders such as obesity and metabolic syndrome, and we think the increase is due to estrone from adipose tissue, higher insulin, and decreased hepatic sex hormone binding globulin. The incidence of HCAs is higher in OCP users, so about 3 to 4 per 100,000 versus about up to 1 per 100,000 among non-users. Adenomas are very estrogen responsive. This is in contrast to like a FNH or focal nodular hyperplasia that they do not grow with COCs. So in this patient population, you would want to stop or avoid COCs and recommend weight loss. Budd-Chiari syndrome is a form of hepatic venous outflow obstruction. The majority of these patients do have an underlying clotting disorder, so you want to avoid any prothrombotic medications. So again, avoid COCs, particularly because they contain estrogen in patients with adenomas or Budd-Chiari. You can use progestin-only pill, the implant, like Nexplanon, the depot shot, and both forms of IUDs, copper or progestin-containing, are safe. So moving on to progestin-only contraception, progestin-only pill, just a reminder, the failure rate's about 9%. And it does really require that the patient take it at the same time every day to be effective. There's no increased risk of clot or hypertension or stroke. Nexplanon, or the subcutaneous implant, very low failure rate. There's no estrogen-related risks. It lasts for 3 years, but it does require a provider visit to place it. The depot shot is an every 3-month injection, failure rate of 6%. It does carry a black box warning for reversible decrease in bone density, so it's really not favored in patients who are already at risk for osteopenia or osteoporosis, which is going to be patients with cirrhosis, cholestatic liver diseases like PBC or PSC, or patients who are on chronic steroids, like patients with autoimmune hepatitis or post-transplant. And just of note, the depot shot is the only progestin-only contraceptive that does carry a little bit higher risk of clot. So in summary, the progestin-only pill and the sub-Q implant is acceptable in compensated and decompensated cirrhotics, and then both IUDs are safe in both groups as well. Can a patient with liver disease use emergency contraception? So just a reminder, this is used within 3 to 5 days of unprotected sex. There are several options. Plan B is now available without a prescription. There's not really data on estrogen-containing emergency contraception in specific liver conditions, but it's such a short duration of use that it's probably safe and unlikely to cause significant harm. Of course, if there's an option, you want to avoid the estrogen-containing options in those 3 high-risk groups with adenomas, Budd-Chiari, or decompensated cirrhosis. And this is just a really nice infographic that's available through the AASLD website under the practice guidelines. It's available even to non-members, but it just kind of summarizes what I just talked about, all the different contraceptive options and which groups these are safe or not safe for. So kind of a handy resource to have. What about assisted reproduction and liver disease? So despite the fact that women with chronic liver disease can have impaired fertility, assisted reproduction has not really been studied very much in this population. There's not an absolute contraindication. However, you do really want to consider the degree of hepatic decompensation. These patients need preconception counseling and risk stratification. You want to involve hepatology and potentially high-risk OBGYNs for these patients. Okay, can women with liver disease be treated with menopausal hormone replacement therapy? So just a reminder, HRT is currently FDA approved to treat menopausal vasomotor symptoms and prevention of postmenopausal osteoporosis, but there's also benefits for other symptoms like sleep disturbance, mood, cognitive changes, and the genitourinary syndrome of menopause. So for patients with liver disease in particular, women with liver disease are, with advanced liver disease rather, are at risk for low bone density fractures and sarcopenia. So HRT can be really beneficial in that population. So we know there's actually potential benefits of estrogen in liver disease. In terms of steatosis, we know that postmenopausal women have an increased risk of visceral adiposity, insulin resistance, dyslipidemia, hypertension, diabetes, cardiovascular disease, all of which, of course, are cardiometabolic risk factors for MASLD. And we do see higher rates of more severe steatosis in postmenopausal compared to premenopausal women. And then in terms of fibrosis, we know that estrogen has an anti-fibrotic, anti-inflammatory, antioxidant effect in the liver, so it can be protective. And we see higher rates of fibrosis progression and advanced fibrosis in postmenopausal women compared to premenopausal women. And interestingly, premenopausal women with MASLD have less severe fibrosis than men with MASLD at the same age, but once they're postmenopausal, their degree of fibrosis is similar to men with the same age with MASLD. So can you use HRT in women with liver disease? So there's some potential concern about the cholestatic effects of estrogens, especially in women with cholestatic liver diseases like PBC, PSC, although studies have shown that HRT does appear to be safe in women, at least with PBC and with PSC by extension of that. So yes, you can use HRT to manage menopausal symptoms in women with chronic liver disease. Again, avoid those three high-risk groups: decompensated cirrhosis and liver function, Budd-Chiari, or hepatocellular adenomas. And then just remember that oral HRT can increase the risk of clot, including rare sites such as the portal vein, whereas transdermal estrogen is not associated with the increased risk. And overall, you need to really consider the individual patient and weigh risks versus benefits, including non-liver related health issues, for example, history of breast cancer, and ultimately decide whether HRT is going to be safe for a particular patient. What about testosterone therapy to manage low T in a patient with chronic liver disease? So symptoms of low testosterone are going to be sexual dysfunction, mood changes, fatigue, bone density loss. We certainly see low testosterone levels in men with liver disease, and it can be associated with sarcopenia, which is a predictor of mortality in patients with cirrhosis. So men with cirrhosis in particular can benefit from testosterone therapy with increases in their muscle and bone mass with a trend toward lowering mortality. It can be associated with transient elevations in liver enzymes that are usually self-limited. So yes, we can use testosterone therapy to treat hypogonadism with chronic liver disease.
Okay. Medications and herbal supplements. So we kind of went through and grabbed their most frequently asked questions, and far and away, probably the most frequently asked question from other providers is going to be in relation to statins, followed by the next six, which we'll jump into.
Okay, so I get this question several times a week from other providers. Is it safe to use statins in patients with liver disease? So statins have shown a dose-dependent effect on liver enzymes, typically mild elevations, less than 3 to 5 times the upper limit of normal. They're transient, asymptomatic. They don't require the statin to be discontinued. It happens in a small percentage of statin users, and it's across all statins. It's a class effect. It's not necessary to monitor LFTs on a statin. And serious hepatotoxicity from statins is really rare. The rate of statin-induced liver failure in the US is 0.2 cases per million. So I just wanted to point out the Liver Tox website. So this, again, is open to everyone. It's run by the NIH. Here's the website at the top. And you can go to this website and you can put in any medication or supplement, and it will actually bring up for you case studies of liver toxicity, how common it is, how severe. So this one is just on statins in general, but you could pull up individual statins. And as Amy will show you, you can look at other medications as well. So very handy. So chronic liver disease without cirrhosis and pre-existing elevated liver enzymes are not a contraindication to using statins. In fact, many patients with these mildly elevated liver enzymes probably have underlying MASLD and they would benefit from a statin. There's a study using NHANES data that revealed that 20% of adults with MASLD, which is an independent risk factor for atherosclerotic cardiovascular disease, were receiving statin therapy, so underused. And just a reminder that the leading cause of death for patients with MASH without cirrhosis is not liver disease, it's cardiovascular disease. What about statins in patients with cirrhosis? So they're, again, probably underprescribed. There was a study that looked at patients with CAD and cirrhosis that were undergoing liver transplant evaluation, and only 23% were on a statin. And we often start statins in our liver transplant candidates with CAD. There's really insufficient evidence to recommend one statin over another. Overall, statins have an excellent safety profile with compensated cirrhosis. And again, that risk of serious hepatotoxicity is rare. You just want to use caution and consider dose reduction in decompensated cirrhosis. What about other benefits of statins in cirrhosis? So there's actually studies ongoing looking at statin use and reduction in risk for decompensation and mortality, specifically using statins to reduce the hepatic venous pressure gradient and thus improve portal hypertension and decrease related complications. There have been studies that have shown a decreased risk of developing HCC, of decreased HCC recurrence in transplant recipients, and following curative resection with statin use. Obviously, we're not prescribing statins for these indications. More research is needed. And this is just a nice infographic, again, from AASLD, just kind of summarizing the clinical evidence on statins from retrospective studies, but pretty impressive in terms of the percentage decrease in hepatic decompensation and reducing hepatic venous pressure gradient and portal hypertension and the lower risk of HCC with statins.
Okay. So the second most common question, I would say I get this more from patients, but also from other providers, is going to be Tylenol versus ibuprofen. And I've actually had this conversation twice already this morning. So acetaminophen is actually the preferred over-the-counter analgesic medication. Multiple studies have shown the safety of acetaminophen in liver disease, and that was looking at a maximum daily dose of 2 to 3 grams per day. We recommend 2 grams a day as the maximum, which is actually 4 extra strength Tylenol. So this isn't baby doses of Tylenol that patients with cirrhosis or even decompensated cirrhosis are limited to. NSAIDs should be avoided in patients with cirrhosis due to potential for kidney injury and GI irritation. So risk for GI bleeding is going to be higher in patients with cirrhosis and portal hypertension, as well as risk of kidney dysfunction goes up in these patients as well. I did want to mention those COX-2 inhibitors in regards to, their GI irritation risk goes down, but the kidney risk remains. So we know that acetaminophen is metabolized by the liver and ibuprofen by the kidneys. It makes sense that ibuprofen would be our preferred option, but it's not. And especially if you work in orthopedics, please spread the word. Acetaminophen is preferred agent over ibuprofen. Next up is milk thistle. So I have this conversation most days, usually with patients who do a Google search, milk thistle for the treatment of liver disease, whether it's autoimmune hepatitis, hepatitis C, or cirrhosis. Milk thistle is something that comes up very frequently as a way to improve your liver health. It has actually had several studies looking into it, and while it does appear safe and well tolerated, it really has no effect on mortality or improvements in liver function among patients with chronic liver disease. So usually what I tell my patients, especially if they're having a really good placebo effect from milk thistle, where they're saying, but I feel so much better when I take it, I say, it's okay to take. It's safe, but it's likely not going to do anything to improve health, and is probably just money that doesn't need to be spent. Turmeric is on the rise as far as these questions because it is being used much more commonly is anti-inflammatory. And according to NIH liver tox, it is now the most common cause of clinically apparent herbal-related liver injury in the U.S. And the reason for it is that now it's just in a lot of things. And so while in low doses, turmeric is probably not going to cause an issue, we don't know what those low doses are going to look like in a lot of these herbal supplements or teas or preparations. So I usually recommend against it. And I found this other study that was looking at the estimated cost of herbal and dietary supplements that is over 11 billion from in sales from 2020, and turmeric is one of the top 10 ingredient for all of these sales. So my recommendation for patients is actually to avoid this completely just due to increased risk. I'm going to briefly mention Augmentin, and what I want you to take away from this is not to avoid Augmentin. If a patient needs it, they need it, but it is the most common cause of clinically apparent drug-induced liver injury. So it's not a nothing antibiotic, and it just needs to be on y'all's mind for a potential drug-induced liver injury cause in patients you prescribe it to. Methotrexate. So this is actually an interesting one. So in my practice, I'm pretty cautious with methotrexate use, and when we're seeing new patients and looking for causes of underlying liver disease in patients without risk factors, methotrexate is something that stands out. And it is going to be important to know that it doesn't always cause elevated liver enzymes, but over time can cause some like mild liver enzyme elevation, but it was thought to lead to a progression in fibrosis. And so this is just kind of a little plug that liver enzymes are not the be all end all of follow-up for liver disease for patients that are on high-risk medications or high-risk patients in general, and using other modalities to measure for progression of fibrosis, like FibroScan, is going to be important and a useful tool to know about for patients that are on these high-risk medications. This study that was published in the Journal of Hepatology recently did find really no correlate between methotrexate use and increased risk for fibrosis or increase in liver stiffness. This was looking at patients with RA and psoriasis. And so the argument that's being made is maybe we're making too big a deal out of methotrexate use. I'm going to continue to kind of go with caution using FibroScan, but the argument is that these patients that are on methotrexate are also going to be at increased risk for metabolic disease, therefore NAFLD or MASLD, higher risk patients. And so maybe that's the trajectory that we see and not methotrexate itself. But again, just use with caution. And then tamoxifen. So this, again, is one not saying not to use it, just understanding that there is going to be a more complex risk-benefit analysis to tamoxifen, and making sure that the patients that are going to be on this long-term, like 5 to 10 years, are reaping enough benefit from the increased risk, because fatty liver has been shown to start developing at the 1 to 3 years of tamoxifen therapy. And it doesn't always come with any symptoms, but sometimes we do see some liver enzyme elevation, but they tend to be pretty mild and not really cause for concern. And then you get a recheck and they normalize. So making sure that you're checking with FibroScan or other modalities to measure fibrosis to monitor over time. And most importantly is going to be aggressively treating those other metabolic disease risk factors that can put them at risk for fatty liver disease and progression of fibrosis. The less common herbal supplements, but still are kind of hot topics right now and come with an increased risk of DILI, are going to be liver cleanses, Lots of time, impulse buys near the register. You see them at Whole Foods. Patients are like, oh, I know what I need, a liver cleanse. Not true. It doesn't tend to do much and often can cause damage. St. John's wort still comes up. More often these days, it's going to be the ashwagandhas, the black cohosh, and the kava as herbal supplements. The ashwagandha and the black cohosh are often used for anxiety. The kava is used a little bit more for patients that are trying to step away from alcohol, but it still has some similar effects. So I recommend against all of those supplements for anybody with liver disease. Okay, jump in topics. We're headed to this question of clearance for elective surgery. I kind of hate getting these requests because it's just like, is the patient cleared for surgery, yes or no? And that's a much more complex question than just a yes or no, and needs to be a conversation between the patient, the surgeon, and then hepatology. We're always happy to kind of weigh in with some risk stratification. But perioperative mortality is 2 to 10 times higher in patients with cirrhosis compared to patients without cirrhosis. The causes are multifactorial, and the risk varies widely based on severity of disease and type of surgery. And this is just kind of a cartoon outlining all the different ways that the liver could potentially make different types of surgery higher risk. I love this flow chart, and so it kind of helps people understand what needs to be done for the risk stratification prior to elective surgery. And right at the top, it's differentiating between elective and emergency. Of course, with emergency surgery, it's you got to do it, and so try and minimize risk and be careful in those cirrhotic patients, hopefully at a place that is used to caring for these type of patients, especially surgeons who are experienced in dealing with portal hypertension are going to be a very, very useful tool. But emergency, you got to do it. But we're talking more about elective surgery. So we're going to look at blood work. We're going to look at liver imaging, discussion of what type of surgery, and understanding the severity of somebody's liver disease. So in a patient without cirrhosis or clinically significant portal hypertension, there's very few limitations as far as what types of elective surgery these patients can undergo. But with cirrhosis and portal hypertension, we do have to be a little bit more thoughtful and cautious going into it. And there are several tools to help answer these risk stratification questions. So vocal pen, Mayo risk, CTP score, as well as MELD scoring. And I'm going to go into a little bit more detail in all of those, but use this kind of tool as a reminder of what needs to be done and when to reach out to hepatology for additional information. So CTP score, been around for a very long time. I love it. I use it. It does include some subjective data, so that's where it gets most of its kind of ambiguity to it. And so it's good that we have other tools out there, but it does help to give you kind of a general risk. So somebody who's CTP-A, we're going to see that 2 to 10% mortality risk. B, it's going to get up a little bit higher. But these are still quite wide range. So even somebody whose child's group C, with a 20 to 76% mortality risk, that's a huge range. So how do we dial that in a little bit more? So we have the MELD score, and currently we use MELD 3.0. Very recently, back in 23, it's been updated. So this is MELD progression over time to include additional objective measures of mortality risk as associated with liver disease. This Mayo post-op mortality risk calculator is also a very useful tool, but it has also been around for a long time. It tends to overestimate risk, and so that's its main criticism, is that it's going to overestimate mortality risks, so patients are a little bit more limited as to the elective surgeries they have access to. And then kind of the latest and greatest is going to be the vocal pen cirrhosis surgical score. And the main differentiation here is that it looks at what type of surgery we're talking about. So in in this calculator tool, you can click on surgery type and it's going to break it down into orthopedic, abdominal, cardiovascular, and assesses risk associated with that type of surgery. So the vocal pen had a 87% chance of distinguishing patients who died from those who did not at 30 days after a surgery, compared to 77% for the Mayo risk score and 72% for MELD score alone. That said, the vocal pen was developed using retrospective data. So it looked at about 4,000 veterans who underwent surgery from 2009 to 2016. And these patients were mainly child's class A and had MELD scores less than 9. And so this isn't necessarily a tool that has been extensively validated in more decompensated cirrhotic patients, so those child's class B and C. Again, still a useful tool. But when I am doing a risk stratification for elective surgery, I actually look at them all. I calculate every single one of these scores and give it in a little bit of a narrative, as well as what my opinion and recommendations are, because we do have to still use that clinician's judgment, critical thinking, as well as these tools. There was a very interesting article published in Hepatology back in 2021. It was an editorial and it was titled Selection of Patients with Cirrhosis for Surgery, as much an art as a science. And it was written to outline the utility of the vocal pen coming out, as well as the other tools that were available for risk stratification, but it also highlighted the shortcomings of these tools and the need for the eyeball test, as well as critical thinking, to be incorporated into that assessment. I think every single one of us has probably seen the frail sarcopenic patient with 10 liters of tense ascites in their belly and a MELD score of 8 or 9. And so these tools don't necessarily represent the whole patient, and none of them very well represent frailty, muscle wasting. And so again, the eyeball test is still going to be important, and you can't just kind of hang your hat on the vocal pen saying, oh, the vocal pen said no real increased risk. So using good judgment remains important.
Okay, so moving on to Masled and MASH, and I'm going to go through some of this quickly because we could spend a whole hour talking about this. But should I be screening for Masled and MASH? It's a resounding yes. And just a reminder, MASLD reflects the change in nomenclature from a couple of years ago. It stands for Metabolic Dysfunction-Associated Steatotic Liver Disease, formerly NAFLD. It's defined by the presence of steatosis with at least one other cardiometabolic risk factor in the absence of another cause of liver disease or steatosis. Global prevalence now in adults is estimated to be 38%. So we are all seeing this every day. About 25% of those with MASLD can have MASH, which is metabolic dysfunction-associated steatohepatitis. And 15 to 25% of them can go on to develop cirrhosis. MASH is now the leading indication for liver transplant in women and in those over 65, and it's on par with alcohol as the leading indication of overall. We know that advancing fibrosis is really the driver of adverse outcomes for liver patients. And patients with stage 2 fibrosis or above, we consider as having at-risk MASH, and we know they have a higher risk of liver-related complications. So who should you be screening? So anybody with steatosis, or if you suspect MASLD based on metabolic risk factors, which I've listed here, be mindful of the high-risk patients. So those with type 2 diabetes, medically complicated obesity, or if they have multiple metabolic risk factors, a family history of MASH cirrhosis, or more than mild alcohol consumption. And your primary risk assessment should be with FIB-4, which I'm going to talk about here shortly. So the FIB-4 should really be your first line risk assessment, great to use in the primary care setting, endocrinology, GI. All you need is the patient's age, a CBC, and a set of LFTs. And if you're using Epic, you can just type in .fib4. There's a smart phrase and it'll calculate it for you in your note. Otherwise, you can use an app like MedCalc on your smartphone. If a patient's over 65, you want to use 2 as your lower cutoff. But essentially, a FIB-4 under 1.3 is considered low risk, and there's a high negative predictive value of 95%. You can exclude advanced fibrosis in that patient. If they fall into the intermediate or advanced fibrosis risk based on FIB-4 1.3 to 2.67 or greater than 2.67, then they warrant a second test. And there's several algorithms out there. AASLD has one. The American Academy for Clinical Endocrinology has one. This one is actually from AGA, and I think this one is probably, I just prefer it. I think it flows a little bit easier. And I'm not going to read through this whole algorithm, but it kind of goes over how to identify patients at risk, do your initial staging with a FIB-4, and then kind of progressing from there to secondary testing with a FibroScan, and then kind of flows into whether a patient's low, intermediate, or high risk based on their VCTE score. And if you want more information on this, I actually did a podcast recently on the nitty-gritty of non-invasive testing that goes over how to use FIB-4, FibroScan, and MRE. But this is a nice resource to use when you're screening and risk assessing these patients. So is my patient a candidate for the new MASH drug? So resmetirom or Resdifra was FDA approved last spring for patients with MASH with stage 2 to 3, so moderate to advanced fibrosis. It's a liver-specific thyroid hormone beta agonist. It works specifically on thyroid hormone beta receptors in the liver. It essentially kind of defats the liver. The Maestro-NASH trial, the two primary endpoints were resolution of steatohepatitis without worsening fibrosis, which was seen in about 25 to 30% of patients, and then improvement in fibrosis without worsening steatohepatitis, and this was seen in about 25% of patients at 52 weeks. Amy, you can.
Yeah, sorry, I was stuck.
So you don't need a liver biopsy to confirm their degree of fibrosis. You can use a FibroScan L for MRE. The imaging-based NITs are preferred. The most common side effects are diarrhea in about 24 to 34%, or nausea in 12 to 22%. These side effects are usually short-lived. I haven't had to have any patients discontinue it based on side effects. You can't use resmetirom in compensated or decompensated cirrhosis. Patients with other uncontrolled active liver disease like autoimmune hepatitis or excessive alcohol use. So this is why you want to make sure you've done your workup to exclude other etiologies of liver disease. There are ongoing trials looking at use of resmetirom in well-compensated cirrhotics. So for my patients with cirrhosis, people are starting to see commercials for this drug. I'll tell them, the reason that we're not putting you on it is that it hasn't been proven to be safe yet in this patient population, but stay tuned. We do monitor LFTs at baseline and periodic intervals, as well as TSH and T4 in patients who have thyroid disease. You can use resmetirom with statins, just be mindful of some of the dose limits. And there was a secondary endpoint in the clinical trial that showed that resmetirom actually did reduce LDL cholesterol, ApoB, triglycerides, and lipoprotein A. This is from AASLD. They actually did amend the practice guidelines for management of MASLD and MASH to include resmetirom. So this just kind of summarizes which patients would be appropriate to use resmetirom. And then in terms of assessing for treatment response, you're obviously monitoring labs over the first year, and then at 12 months, typically doing a FibroScan to reassess fibrosis. Certainly if a patient, if their fibrosis score gets worse or their ALT is getting worse, you would consider them a non-responder and stop treatment. A positive response would be an improvement in their FibroScan score by 25% or MRE by 20%. And in those patients, you would definitely see benefit. You'd want to continue resmetirom. And then there's sort of the gray area with patients that maybe don't have that significant of a positive response, but you think maybe more time is needed. And so you consider continuing them on treatment. Okay, so moving on to GLP-1s, kind of a hot topic today. What about semaglutide? So this is a phase 3 trial of semaglutide in MASH patients with biopsy-proven stage 2 to 3 fibrosis who were on 2.4 milligrams of semaglutide versus placebo for 240 weeks. And this study was actually an interim analysis at 72 weeks that just looked at the first 800 patients. And you can see the results here. So in terms of resolution of steatohepatitis with no worsening of fibrosis, there was about a 63% response rate in the semaglutide arm. And then in terms of improving fibrosis without worsening steatohepatitis, about a 37% response rate in the semaglutide arm. What about tirzepatide? So obviously it's a newer drug. There is a phase 2 trial, again, looking at patients with biopsy-confirmed MASH with stage 2 to 3 fibrosis, once weekly tirzepatide versus placebo for just 52 weeks, so shorter. Same primary endpoints. In terms of resolution of MASH without worsening fibrosis, you can see with the 3 different dosages of tirzepatide in the 15 milligram group of 62%. And then in terms of decreasing by greater than 1 fibrosis stage, over 50% response rate in the tirzepatide arms. So can use of GLP-1s actually improve outcomes for these MASLD patients? So there's actually multiple large studies and real-world data that indicate that use of GLP-1s in patients with compensated cirrhosis can reduce the risk of decompensation and all-cause mortality. The benefit's less evident if they've already reached decompensated cirrhosis. And just a couple notable studies, Barrett et al. Last year, greater than 4,000 patients with MASLD and diabetes. There was a significant reduction in both overall mortality and progression to decompensated cirrhosis in GLP-1 users compared to those who were not on GLP-1s. And then Conwell et al. Last year, this was a cohort study with over 16,000 patients with MASLD and diabetes. And again, GLP-1 use was associated with a statistically significant reduction in the risk of progression to cirrhosis and complications, but the benefit was seen more in patients who initiated the GLP-1 earlier in their disease course. So are GLP-1s safe in patients with decompensated cirrhosis? So you can use them, but you need to be cautious. So these are patients that already have a risk or already have malnutrition and sarcopenia, and both of those things are associated with increased complications and higher mortality in cirrhotic patients. So we worry about the significant lean body mass loss with GLP-1s in this patient group. So you can use them, but just monitor them very carefully for malnutrition and sarcopenia. What about GLP-1s and alcohol use? So also some exciting data here. So GLP-1s have been associated with reduced alcohol use and decreased risk of alcohol use disorder. There was a study in JAMA this year in patients taking semaglutide reporting a reduced alcohol use and alcohol cravings in adults with alcohol use disorder. Another study with individuals taking semaglutide that reported 20% stopped drinking completely and about 88% reported reduced cravings for alcohol. And then another retrospective study with over 80,000 health records from patients with obesity that were on semaglutide, and it was associated with a over 50% lower risk of developing or recurring alcohol use disorder within a year compared to other anti-obesity drugs.
Okay, we're going to jump over to hepatic encephalopathy, and we're actually doing pretty okay on time. So I'm gonna take a little bit more time on hepatic encephalopathy, just because I do think there's a little bit of room for improvement and understanding as to kind of what the problem is and how to manage. So hepatic encephalopathy is a problem that's caused by ammonia, and ammonia is a byproduct of protein breakdown in the gut. And when there's normal blood flow without liver problems, that blood flow goes right through the liver, the ammonia is dealt with, and so you don't deal with elevated ammonia levels in the blood. But if you look at these two graphics, it's kind of just showing the difference in blood flow being rerouted around the liver. And so sometimes the ammonia is not dealt with as effectively. So ammonia in itself is not a problem. Everybody has ammonia in their blood, but we have it at manageable levels. And in hepatic encephalopathy, the ammonia has increased to the point where there is enough of it crossing the blood-brain barrier and acting directly on the brain that it causes problems. And so how we treat it is with lactulose, Xifaxan, Miralax, and Lola. And the gold standard of hepatic encephalopathy treatment is lactulose. And it's not just lactulose for lactulose's sake. It's not like 4 times daily dosing. Everybody gets it and controls it for everybody. And also not everybody with cirrhosis has hepatic encephalopathy. So not everybody with cirrhosis needs to be on lactulose. And it is important that we are titrating the lactulose dose to bowel movements. And so the bowel movement is so much more important than how much lactulose somebody is taking. And I commonly tell patients, I really don't care how much lactulose they take, so long as they're taking it to start with and having 3 to 4 loose bowel movements a day. For some patients, they don't need the 3 to 4, and you can get away with the 1 to 2. Really, that mental clarity is going to be the important piece. And so, if they're having 4 bowel movements a day and they are still consistently confused, having hospitalizations because they become somnolent and the family members bring them into the hospital, very understandable. Upping the lactulose can address that, but it does increase those bowel movements. So adding Xifaxan to their current lactulose regimen is a good next step. Some patients are able to maintain on Xifaxan alone, but it is very rarely, I very rarely start with Xifaxan. I do sometimes, but usually I'll trial lactulose to get somebody started and see if there's an improvement. Miralax is gentler than lactulose, and so somebody who's having a lot of issues with side effects, and again, I'm not talking about bowel movements. That's not the side effect, that's the effect. I'm talking about like the gas, the bloating, or nausea, vomiting related to the syrupy sweetness of lactulose. Miralax is a good kind of baseline, and then you add lactulose onto that to get to those desired bowel movements. Lola, not FDA approved. You can buy it online. Anecdotally, I have several patients who say it was the game changer for them, and I have other patients who say it makes no difference whatsoever. But it's safe, relatively cheap. It is an out-of-pocket cost, but something that patients can try if all of these other things are not getting them to kind of that mental clarity goal. So with hepatic encephalopathy, when it's under good control, or if it's out of control, actually, in any situation, things to avoid are going to be CNS depressants in general, specifically opioids, anticholinergics due to constipating effects, but also consider the effects of GLP-1s, like we just talked about, iron supplements, things that can cause constipation. Put these patients specifically at higher risk of having an event where their encephalopathy gets out of control, they end up in the hospital. And so keeping in mind that bowel habits or any medications that affect bowel habits, as well as CNS depression, need to be kind of used with caution. So as I said in the beginning, so protein breakdown is how we get the ammonia. So is protein the problem? So yes, if nobody takes in any protein, there's potential that there would be a little bit less ammonia, but really the answer is no. By limiting somebody's protein intake, it really hasn't been shown to have significant improvement in their hepatic encephalopathy symptoms, and it can be very detrimental to the patient's health overall, because the other problem that comes up so often in cirrhosis and portal hypertension is sarcopenia. And so for these patients, limiting protein intake causes a lot more problems than it potentially helps. Cirrhosis, with or without hepatic encephalopathy, is a catabolic disease, and decreased protein intake can lead to increased risk for sarcopenia. And prevalence of sarcopenia in cirrhosis is actually quite high, 30 to 70%. Women tend to be at higher risk, but it happens, or it can happen to everybody. So if it's not the protein, it's the ammonia problem, right? And yes, ultimately, ammonia is the problem. So should I be monitoring ammonia levels? It's a good question. And I love those objective measures to be able to like dictate care based on those objective versus a patient telling me how they're feeling or what small changes have been made. But in this situation, my most often answer to that question of checking an ammonia level is no. The exception being is this hepatic encephalopathy or is this something else like dementia, delirium, drugs, poison, chronic fatigue? It is reasonable to check an ammonia level to rule out another or to rule hepatic encephalopathy out. This comes up most often for me in chronic fatigue and in dementia. And so if I have a patient that the symptoms aren't quite classic for hepatic encephalopathy, but could absolutely be like a contributing source, um, especially dementia patients. What I'll do is I'll check an ammonia level when they're actively having symptoms. So if they're sitting in clinic saying, I am dead tired, I'm having trouble getting out of bed, this fatigue because of my hepatic encephalopathy is so overwhelming, and the increase in the lactulose is doing nothing. In that situation, checking an ammonia level to kind of prove to the patient that this is not hepatic encephalopathy, or in the dementia situation to prove to neurology that this is not a hepatic encephalopathy problem, is a good use of that ammonia level. But checking like weekly ammonia levels and dictating care based off of those ammonia levels is not useful. In cirrhosis, just having an elevated ammonia level is not a reason to change the treatment regimen, because if you've got somebody on lactulose and Xifaxan and their symptoms are under good control, but their ammonia level is elevated, you don't need to increase their lactulose just based on that ammonia level, so long as they're not having issues with brain fog or other symptoms of HE. It really is all based on symptoms, so that ammonia level is not helpful. Comparing one patient's ammonia level to another patient's ammonia level is also not useful. So somebody could be having pretty significant hepatic encephalopathy symptoms with an ammonia level of 70, while somebody with an ammonia level of 150 is doing just fine. And so keeping in mind it's all symptom based, and serial ammonia levels are not reliable measures of disease severity, effectiveness of treatment in an alert patient. Go by how the patient is doing, how the patient is feeling, versus watching an ammonia level drop from 80 to 60. Okay, so cirrhosis versus liver failure. This comes up a lot, especially in patients who come to us like directly after an emergency room visit, or their orthopedics did some imaging and what's described as a cirrhotic appearing liver. And so they're being told that they have 6 months to live, or they need a liver transplant, or whatever the case may be. Cirrhosis and liver failure are different things. Having cirrhosis puts somebody at higher risk for liver failure, but cirrhosis really just means scarring in the liver past the point that the liver can regenerate itself. And so it doesn't necessarily mean that there is any function problem whatsoever. So somebody can have completely normal liver function and have cirrhosis, where liver failure and symptoms of liver failure are why we do transplants, plus liver cancer. But the important takeaway is cirrhosis is not a death sentence. It is a chronic disease that requires management, but doesn't necessarily need a liver transplant. And so, talking about liver transplant, it is not our first. It's not our first step, not our first line treatment. It should be considered when medical management has failed, is failing, or will fail. And so for a patient with very severe liver disease and symptoms of liver disease that are in their 40s, and we don't have control of that liver disease. So for example, somebody with primary sclerosing cholangitis, we don't have treatment for PSC. And so the likelihood that there's going to be progression to needing a transplant is high. But for somebody with alcohol-associated liver disease, fatty liver disease, MASH, autoimmune hepatitis that is untreated, PBC that is untreated, there's a lot of steps between that diagnosis of a liver problem and the need for liver transplantation. So recognition of cirrhosis is important because it does require additional management, but doesn't equate to need for transplant. So they need to be screened for hepatocellular carcinoma, varices, HE, ascites, SBP, and then aggressively monitored and treated to avoid sarcopenia and frailty. But not necessarily first line of treatment is never liver transplant. Okay, and then hot topic of the last few years is the 6-month sobriety rule. So 6-month sobriety has been shown to be a very poor predictor of alcohol relapse after liver transplant, and it encourages dishonesty and doesn't encourage patients to be actively engaged in their alcohol use disorder treatment. Also, unrealistic barrier to liver transplant, especially in severe alcohol-associated hepatitis, which by definition the patient has consumed alcohol recently. 75 to 90% of those patients with severe ALK-HEP are going to die within the first 2 months. And so limiting access to transplant is something that has really changed over the last 5 years. And so this 6-month rule is not part of our practice really at all. It's on a case-by-case basis related to disease severity. So severity of liver disease is really important, but also severity of alcohol use disorder, engagement in treatment. All of those factors play a much bigger role than just this kind of arbitrary 6-month rule. And so there is no 6-month rule. If there's a patient that you're advocating for who you feel would be a good liver transplant candidate, has good insight to their disease, actively addressing their alcohol use disorder, then it is perfectly appropriate to refer for transplantation if they're meeting those criteria of symptoms of liver disease that are not getting better with medical management. All right, whole bunch of references. Thank you guys so much. Here are Lindsay and I's emails. Feel free to reach out with questions related to this talk, patient care. Always happy to jump in and help if we can. Don't forget about this Rocky Mountain highlights in gastroenterology and hepatology in a few weeks on August 9th, and get registered for that. And then also don't forget to do your CME evaluations by the end of the month. All right, we have 3 minutes. We did it for any questions. I haven't looked at the chat once, so if there's any questions in there, let me know. Doesn't look like there's any questions in the chat. Okay. Only one question in the chat. All right. All right, no problem. Yep. If there's any additional questions, like I said, I'll flip back over to our email and feel free to reach out.